Explain procedure and general steps, as patient compliance is important. Positioning and preparation are key. Upright positioning is preferred, as it is easier to identify the midline and locate the interspinous space. Position the patient sitting over the side of the bed with a chair supporting the feet and the hips at greater than 90 degrees flexion. Provide a pillow to help patient slump forward, allowing maximal flexion of the lumbar spine. This provides the best opening of the interspinous space. Palpate the landmarks. Palpate iliac crests. These are at the level of L4 spinous process. Palpate interspinous space above and below L4 spinous process and choose larger space. If difficulty locating space is encountered, use ultrasound with the probe oriented vertically and just off midline, allowing identification of the spinous processes, the space between, and the ligamentum flavum, which is brightly radiopaque compared to other structures. In experienced hands, a transverse probe position may be used to determine the best angulation of the needle for the approach. Mark the skin. Using a cap of a needle to indent the skin via sustained pressure for 5 to 10 seconds is suggested. Skin marker is an alternative. Set up your equipment. Use sterile gown, gloves, mask, and eye protection. Prep and drape. Confirm landmarks to improve spatial orientation. Inject 1% lignocaine subcutaneously and proceed with stepwise deeper injection down to the interspinous ligament. 5 milliliters should be sufficient. However, observe maximum dose of 3 milligrams per kilogram. Use pencil point lumbar puncture needle. 22 to 25 gauge is recommended. Insert cutting introducer needle in midline axis with incline angle towards the umbilicus. Insert most of the way in to allow enough purchase in the tissues to maintain insertion access. Be aware in small adults or children not to puncture the ligamentum flavum with the introducer cutting needle. Insert the lumbar puncture needle in the axis of the introducer. Maintain pressure, feeling for increased resistance of the ligamentum flavum. If bony resistance is felt, remove the LP needle. Pull out the introducer needle until the tip is subcutaneous and reinsert, changing incline angle by 5 to 10 degrees. Reinsert LP needle in the axis of the introducer. If bony resistance is felt again, follow same sequence and change incline angle in the opposite direction. Ensure vertical axis remains between umbilicus and pubic symphysis. If radicular leg symptoms occur during LP needle insertion, follow same reinsertion sequence and angle introducer needle 5 degrees contralateral to the side of radicular symptoms. Ensure that introducer needle is used to change axis and LP needle itself is not used for directional change. Remove stylet and check for CSF flow. Allow adequate time for flow, especially with smaller gauge needles. If there is no flow, advance the LP needle without stylet 2 to 3 millimeters at a time, checking for flow at each point. You may feel release of pressure once past ligamentum flavum or a pop when going through dura. Once CSF flow identified, collect sample. You may use the stylet partially inserted to control flow between samples. Collect 15 drops per sample bottle. Collect number of tubes appropriate for your center. Once samples collected, reinsert stylet fully prior to removal. Remove introducer and LP needle stylet complex as one. Apply dressing to puncture site and send samples to laboratory. If opening pressure is required, patient is too unwell to tolerate upright position or operator preference, Lateral recumbent position is appropriate. Positioning is particularly critical in lateral recumbent position. Ensure patient's hips are at maximal tolerable flexion to optimize interspinous space. Ensure knees are together and shoulders are in the same position vertically to prevent spinal rotation. Aim to position lower back in the vertical plane. Identify landmarks as before, palpating iliac crests and identifying L4 spinous process. Select space to be used. Ultrasound can be used to assist. Mark skin. Follow same setup and preparation sequence as before. Main difference in technique is the relative axis of insertion. With patient positioned correctly, needle axis is parallel to the floor and perpendicular to patient's back, with lateral axis between the umbilicus and pubic symphysis. Follow same sequence including local anesthetic injection, insertion of introducer needle and lumbar puncture needle. Follow same sequence for bony resistance or radicular pain. Once CSF flow identified, measure opening pressure. You may use stylet partially inserted to control flow. Attach manometer, hold zero marker at LP needle level and position manometer vertically. Wait until CSF column stabilizes and note pressure. Disconnect manometer and empty manometer CSF into first sample bottle. Follow same sequence to collect samples. Reinsert stylet fully prior to removal. Remove introducer and LP needle stylet complex as one.